Okay, so today we're going to cover the musculoskeletal system. Now we know there are two major types of muscles in the body, right? Muscle and skeletal muscle. So anytime you see the word osteo, that has to do with bone. Osteoclast, osteoma, the bone, osteocyte, the cells in the bone, and osteitis, inflammation. Chondro is cartilage. Chondritis, chondroma, chondrocyte. So those are the type of specimen. Sometimes we will see it in the bone. There's a specific kind of bone tumor associated with usually young adolescents, Ewing sarcoma. So those are the ones that we often see, even though it's a rare tumor, but we've seen quite a few cases of those, just because I think we have a children's hospital here. So joints are arthroarthritis, we've seen that very commonly seen. Angioplasty during the construction of the joint. Bone marrow, myeloma, cells in the bone marrow that have growing out of control. Okay. Usually it could be a benign condition, it could be a malignant condition. Okay. Tendon, tendinitis, binding muscle in the bone on the tendon. Ligament, here ligament is pretty self-explanatory. Bursitis usually means there's a bag, okay, some sort of a sacs in the body. And bursitis, it acts as a shock absorber, usually between the tendons and the joints. Like there's one on your knees, there's also one on your shoulders. Okay. So muscles, myoma, myositis, malacia, softening, osteomalacia, softening of the bone. Usually there's a condition where insufficient calcium, or there's usually seen in more of the elderly patient. Okay, there is not as compact. Porous osteoporosis, especially in older female, that a lot of time they do not have the compact bone, and that occurs more in Asian as well, because they do not have a lot of milk product in their diet when they were younger. So in general, Asian women are more prone to osteoporosis. Okay, and the person that also female in the smaller frame are more prone to that. So calcium, exercise, weight-bearing exercise particularly will increase the compact of the bone and make them strong and not so brittle and easily broken. Okay. Asthenia, weakness, lot of strain, trophy development, atrophy, shrinking, hypertrophy, oversize, overgrowing. Okay, so these are the terms we often seen in cytology specimens. Okay. Pain, algia, malacia. Malacia just means the muscle pain, overall aching. There's not really a specific area, just overall muscle aching. Okay, so musculoskeletal disease, I think we covered this pretty much. Oh, carpal tunnel syndrome. This is one of the chronic injury over time, okay, that is particularly common seen in our profession. Because when we do the screening with the microscope, our hands keep using the knob turning. So over time, we use a lot of this repetitive movement, so-called. Okay, so it's very commonly seen in people that do office work, the ladies that are using a lot of typing. Okay, that could also hurt there because there's repetitive movement of the fingers and the joint and the wrist here. Okay, so carpal tunnel syndrome very commonly seen. And sometimes in severe cases, they will require surgery to correct that. Okay, it's a very painful kind of a chronic aching process. Right. Tendinitis, again, strain on the tendon. Tendinitis could occur pretty much everywhere in the body. Okay, particularly in athletes, that occurs a lot. Rotation cuff tear, again, that could also do with athletic, or sometimes in work environment too, where the people have to do a lot of this kind of a movement, especially pulling and pushing, okay? So bursitis, again, fluid in the bone. Let's see. Okay, muscular dystrophy. Muscular dystrophy, nowadays is getting a lot more commonly seen for some reason, okay? It could occur in older female or older male, as well as some of the younger patient group too. Okay, it's an inherited disease. And the most common form in children is called the Duchenne muscular dystrophy and affect only males, so the patient has very atrophic muscles and there's not much of the function at all. Okay, between usually young, age up to 6, and then also kind of skip it in the early adolescent and in the late teens. Okay, the two age group is particularly prone to that. Okay, lupus is an autoimmune disease that's seen a lot in female particularly. Okay, so systemic lupus involve inflammation of multiple organs, and a lot of time it could be very affected the people's daily life. Okay, I've known a lady that has severe lupus, and her joints on her fingers was all twisted. So she has difficult movement of the joints and even holding objects in her hands. Okay. So. Okay. Procedure, rheumatologist. Okay, I think we're gonna skip all that. Physical therapist, I think pretty much everyone is familiar with physical therapists when you have some sort of an injury to your body and they do all that exercise trying to build your muscle back and do those safety training kind of thing for your body. Okay, so we can skip that. Medical history. Okay, let's go into some of the cancer term. This is probably more commonly seen than anywhere else because the specimen we look at every day is either you're looking for benign cells or you're looking for malignant cells. Okay, so we see a lot of this. Benign meaning good, malignant, cancerous. Okay, that's what it means. Low grade, usually the differentiation of the cells, in cytology, we classify them from low grade to high grade. Okay, moderate is sort of a difficult kind of a gray area. Low grade meaning that the cells in general are very close to their normal appearance, what they call low grade. Okay, whereas high grade meaning the cells look very different from how they originally look. Okay, so for low grade carcinoma, meaning that the cells become cancerous, but is still very recognizable from their original state, maybe squamous cells or glandular cells. Whereas a high-grade tumor, or what we call poorly differentiated, meaning that the cells still have somewhat of an origin look, but they become very irregular shape, very pleomorphic. Okay. Radiosensitive, when they do the radiation therapy for cancerous patient. Radiosensitive meaning that the cells are reactive to the radiation. So whenever there's radiation, it's kind of like zapping the cells, it destroyed it. Okay, that means they're radiosensitive. Radio-resistant, that radiation has no effect of them. So those are the kind of cells that are a little bit more difficult to treat. Okay, again, well differentiated, low grade, poorly differentiated, high grade. Okay, negative nodes pertaining to the lymph nodes. Okay, you know that cancer cells could spread through the body, through the lymphatic system, the lymph node, also through the bloodstream. Okay, so for example, a female patient that have breast cancer, when they remove the breast in a procedure called mastectomy, very commonly they need to check whether there's any kind of malignant cells that have spread through, their lymphatic system, particularly axillary lymph node. Okay, so what they do is they need to take out a lymph node called the sentinel node to examine it. If the sentinel node is negative, that means that they only need to perform a simple mastectomy to just take off the breast and some tissue. That's all. They don't need to do the lymph node dissection. If the sentinel is positive in the breast cancer case, then they need to do what they call the radical mastectomy. In addition to the breast organ itself, they also need to take out the whole bunch of lymph node in the axillary area. Okay. So negative node is always good. That means the cancer hasn't spread that far. Positive nodes, that means the cancer has already spread. Okay. In remission, that's good. That means the patient is completely recovered at the time. There's no cancer cells, no disease in the body. Relapse is when the cancer come back, recurrent. Okay, the disease coming back. Surgically resectable, again, in the organ that if they are able to do surgery, they take off the whole thing and they basically cure. But if inoperable, if the tumor or is growing too close to a major blood vessel or is wrapping around a very bundle of nerve or is growing inside of the space that is hard to get to anatomically inoperable, that's usually harder to treat. So, tumor types, malignant versus benign. Tumor, remember the word tumor is just meaning a growth, a swelling of a mass in the body, okay? Tumor, the word by itself does not tell you whether it's benign or malignant. So we have benign tumor and malignant tumor. Benign tumor, such as fibroadenoma of the breast, is a benign growth of fibrous tissue and ductal cells in the breast. Okay, breast cancer, that's a malignant tumor in the breast. Okay. For the lung, hematoma is a benign growth in the lung. Lung cancer is a malignant growth in the lung. Okay. Carcinoma is the form of cancer developed from sheets that cover the surface, epithelium, okay, or line the body cavity. So epithelial cells is the major type of cells that we've seen pretty much in cytology specimens. Okay? We see also other types too, but majority of those are going to be carcinoma. Squamous cell carcinoma, like the one we talk about it, briefly mentioned it in the other lecture. Glandular cells, the cells in the stomach, the glandular cells, adenocarcinoma. Those are the epithelial cell carcinoma. Okay. Now, sarcoma is a cancer type that arises from connective and supportive tissue. So this is a more aggressive type of tumor, but it's extremely rare in comparison to carcinoma. Okay, carcinoma is much more commonly seen. You can see pretty much in every major organ, the pancreas, the liver, the stomach, the lung, the breast, etc. Whereas sarcoma involves bone, fatty tissue, muscle, so osteosarcoma, malignant tumors in the bone, fibrous tissue sarcoma involving fibrous tissue, and liposarcoma involving fatty tissue. Okay, grading and staging. Grading and staging is very important in disease, especially cancer diagnosis. Okay, there are two major distinctions. A grading scale is used, usually grade 1 to grade 4, to describe the tissue differentiation. So for the well-differentiated tumor, that means the cells still look like the original tissue. Okay, so usually a grade 1 tumor is better than a grade 4 tumor. Okay, the grade 4 tumor is much more aggressive usually. It does not really resemble the original tissue. Now, for the staging, this is a very important, the letters T, N, and M. T stand for the size of the tumor. Okay, usually a 1 centimeter is much better than a 3 centimeter because it's smaller. The smaller the tumor, the better. N stand for node, lymph node. Okay, Then M stands for metastasis. So first they look at the size of the tumor, how big it is, and next they look at the node, the lymph node nearby, whether it is positive lymph node or negative lymph node. And finally M, they look for metastasis, whether the cells have spread to other further sites on the body. Okay. So for example, melanoma is a very deadly skin disease, okay, that very commonly seen in a lot of UV exposure usually that cause it. Now a T2N0, M0 describe a skin cancer that is between 1 and 2 millimeter in thickness, T2, okay, but has not spread into lymph nodes, so N0, and no other areas of the body, M0. Okay, so that means that this is still a very small tumor confined to the surface of the skin. If they surgically remove it and keep the patient a close watch, the patient are basically cured at this time. Okay. Now on the other hand, if it's a T2N1 M0, that means that the lymph node has already been positive. The cancer cells spread to a nearby lymph node. Okay, if it's on the surface of the skin or somewhere on the arm, it may have spread to the axillary lymph node. Okay, if it's on the back of the skin, it may have spread to the head and neck lymph node. Okay, so anytime when you see T2N2, the TNM system, that's what we call. Okay, is for the staging. So a grade 1 tumor with a T3N0, M0, okay, and another tumor, a grade 3 tumor with a T1N0, M0. Which one have a better prognosis? Is easier to cure? Which one? T1? But it's a grade 3 though. So a grade 1 is still much better, easier to treat, okay? Meaning that it's not as poorly differentiated or highly differentiated, okay? So anyway, so that's just some of the common terms that you will see in a pathology report. Okay? Anytime when they resected the tumor from the surgery room, they send it to pathologists. So and the pathologists, when they look at it and dictate a report on the pathology report, I'll show you a real report later on that you're going to see, for example, left breast mastectomy, grading system grade 3, for example, TMN system T1, N0, M0, things like that. Okay, so this is all stated in their pathology report. Now, why is all this information relevant? Why is it important? What do you think? Why do we have to say specifically what grade and what stage of a tumor? Why is that?
To tell the patient more information.
What does the patient have to do? What do they do with all the information though?
Make a decision on treatment.
For the clinicians that are treating the patient, the oncologists, okay? It's not necessary for the patient. To a patient, it may not mean much if they do not really have a lot of the medical knowledge, okay? They look at the report and say, oh, okay, that's what it means, but it doesn't really make any sense to them. But for oncologists and the clinicians that are treating them, that's extremely important, okay? It determines how much radiation of the dosage that the patient is going to need, how much chemo dosage, or what kind of chemo specifically that is going to need to be treated for this patient, okay? So all this information is really important to the radiologist oncologists that are treating the patient, okay? It will tell them exactly for this type of tumor, they need this specific chemo drugs for this kind of a sign of disease of a tumor of this size with metastatic tumor, lymph node positive, it needs this much dosage. Okay, so those are all the information that would be very important on treating the patient. For the patient herself or himself, it's just another piece of information. It doesn't really make sense to them, okay, too much. But for their physician, it's been very useful. here, grading and staging tumors are important ways to predict the prognosis. This is the word that you will hear a lot. Good prognosis, medium so-so prognosis, or bad prognosis. All this have progress and outcome of the disease, meaning that from the day that being treated until 5 year on, we usually call the 5-year survival rate. What is the chance of the patient being still alive and disease-free, usually, okay? So, say for a grade 1 tumor, T1, N0, M0, for the 5-year survival rate of the patient is probably 80 to 90%, okay, at this time. Has a very small tumor, have no metastasis, no positive lymph node, and a very well-differentiated grade. The patient has a very good outcome, very good prognosis, okay? On the other hand, if it's a melanoma case, that's grade 3 or T5, N2, M1, that the prognosis compared to the first patient will be much worse, okay? The chance of survival may be 10, 20%, for example. I'm just making up the number, okay? So that's why it's very good to have all this predicted outcome for the patient. So for the physician, then they know, oh, okay, 5 years from now, you probably don't have to worry about it, okay? Things like that. Of course, nobody knows for sure when the tumor is going to come back, okay? Hopefully, it will never, so. Okay, cause of cancer, there's not a single cause, so to speak, okay? There are all these risk factors that add up on top of one of another, okay? It could be a genetic mutation, it could be environmental factor, it could be hereditary from a DNA, okay? It could be a mutation from a gene, okay? So all this could be a virus infection. So all these are risk factors that add up on top of it. There's not one single cause that will say, this is why the patient has cancer because of this, okay? For example, even HPV is the major cause of cervical cancer, but is that the only cause of cervical cancer? No. There are other high-risk factors, such as multiple sexual partners, okay, having intercourse at a very early age, haven't been doing the checkup, things like that. Smoking being one of them, okay. So it's just one of the major cause of cervical cancer, but it's not the only cause. Tumor markers. Now, we do a lot of tumor markers in cytology. Tumor markers are substance that we call immunostain. They're produced by tumor or the body's response to presence of tumors, okay? So what we do is whenever there's tumor markers, we do immunostain to test for it. For example, CA125 for ovarian cancer. Now, it's a marker that would be helpful in diagnosing ovarian cancer, but it's not a marker specifically for ovarian cancer, okay? Just because a patient have a CA125 elevated level does not mean that the patient is going to have ovarian cancer for sure, okay? There are other false positive, false negative causes that could add to it. Another example is the prostate, PSA, prostate-specific antigen. Just because the PSA level is elevated does not mean that the patient is going to have a prostate cancer. Other things could cause that too. Chronic prostatitis, it could cause the elevated of PSA level, okay? Or even a benign hypertrophy could cause the elevated level. So it's a useful marker to help in the diagnosing, but it's not definitive proof. Radiation, the kind of agent that could cause cancer, but they could also use to destroy cancer, is like they're zapping the cells, okay? Now, keep in mind when there's radiation exposed to the body, for example, if you're doing a chest x-ray, chest CT scan, that's exposed to pretty much the full body, right? even the chest X-ray that's being this much here, majority of the thorax area. With radiation treatment, it's very different. They pinpoint the location. Say if the patient had breast cancer, they pinpoint the location to really specific or very close to the tumor site, okay, so that the rest of the body would not be exposed to it. Radiosensitive cancer cells degenerate in response to the radiation. Radio resistant, then it does not respond or only have a partial response. So each different patient and each different disease would require a different dosage of radiation. And it's usually done for radiation therapy, it's usually done over time. They are not going to zap the whole radiation dose on patient in 1 day or 2 days, okay? Usually what they do is it's spread out maybe 6 to 8 weeks, for example. The patient will come once or twice every week to the hospital and have a small dose of radiation zapping the cancer cells, wherever that is in the body. And then over time, then the tumor is going to either respond to it or not respond to it by shrinking and the cells dying. Okay. Now when radiation are zapping the bad cancer cells, inevitable, sometimes they would also affect the normal healthy tissue surrounding it. Okay, there's not exact clear cut that say, nope, you only focus on cancer cells. Sometimes inevitably there's going to be normal tissue surrounding the tumor cell size that's going to be affected. And those are some of the changes that we would see on a cytology specimen. For example, cervical cancer, squamous cell cancer. After the patient have a hysterectomy, remove the uterus, oftentimes the physician will do a small, short course of radiation just to make sure that it cleans up all the tumor cells. Now, the radiation that affect the normal benign cells in the body surrounding that area could have a long-term effect, meaning that the cells will maintain their changes, the radiation changes, so to speak, for at least 3 to 5 years. Okay, so that's why it's very important to look at the patient history. If a patient already have cancer, have been radiation therapy treated, now any time after that when they come back for a follow-up every year, when you look at the specimen again, you need to keep in mind that there are going to be radiation changes cells involved in the specimen, okay? So you would keep that in mind and not to overcall those cells that look different than the normal one and calling it something bad. Okay? So that's why it's important to know about the patient history. So radiation and chemotherapy pretty much affect the body the same way, they're killing the cancer cells but also affected the tumor cells, the healthy cells. Now, the major difference between radiation and chemotherapy is radiation is localized in specific area of the body, whereas chemotherapy is systemic. It goes into the bloodstream. Okay, it affects the whole body. So that's the major difference. And oftentimes, the first thing that usually affected by either chemo or radiation are the surface skin cells, hair cells. You've probably seen patients that are being treated by chemo radiation. Sometimes they get their hair loss, okay, and they have vomiting, diarrhea. Those are all the side effects because the body reacting to the agent that's treating the chemo cells. Okay, surgery, different kind of procedure. Cryosurgery, destroying the malignant tissue by freezing it with a cold probe. Okay, so usually cryosurgery, sometimes they did it in a cervical tumor too. Focalization, lining with electrocautery, using an electric current, doing it, zapping it. Excisional biopsy, removing it, the whole tissue. Okay. So those are pretty much very commonly seen. Okay, medical record. Let's take a look at this medical record since we've learned all this thing. So in this patient record, a 55-year-old male has noted changes in his bowel habit and recently has a positive gout test. What is a positive gout test? Can you guess? Blood and stool. Okay, so that means the blood and stool. Colonoscopy reveals a suspicious lesion. So he has a clinically suspicious lesion on colonoscopy, and clinically he also has a blood test on the stool that is positive for blood. Okay, so usually they give them a little package to go home, and then when the patient goes to the bathroom, they put a little of the samples into the package and send it back to the lab. And they use a specific reagent, put it on it. If it changed color, that's positive. Okay, that's how it's done. So a biopsy examined by a pathologist revealed a grade 1 adenocarcinoma of the upper rectum. Is grade 1 adenocarcinoma easy to treat or hard to treat?
Easy.
Probably easy, right? It's a low-grade tumor. Okay. Unblocked resection of the lesion was performed. What's unblocked resection? It's like cutting right there. Okay. Staging indicates this tumor has spread beyond the area involved. So in the staging, it's already have spread, metastasis. Okay. And there are positive notes indicating local metastasis. The oncologist recommend follow-up with adjuvant therapy in case any tumor cells escape, and this type of tumor is radiosensitive. Okay, so when you read this patient record, there are a couple of words that you've already learned, that you understand what it means. Okay. So let's see. Okay. We're not going to do this one. Let's wrap up. Let's see. Okay, so there's a final quiz. I'm going to let you guys work on it later on your own. Okay, let's see. Any notes? Okay, you could read through this later on. Okay. Let's take a 5 minutes break and then we'll come back.
Okay.